Hello everyone, this is Dr. Momo, and we want to quickly talk about the emergencies in endocrinology. So we'll be very brief and we'll talk about the glycemic, talk about the thyroid, and then also the adrenals. So look at emergencies in these three areas of endocrinology. And for the glycemic, we just look at the hyperglycemic emergencies. In this, we just talk about the DKA and also the HHS. And then for the thyroid, we talk about that of the hyperthyroid emergency. And this we talk about the thyroid storm. And then also we talk about the hypothyroidic emergency. In this case, we talk about the hypothyroid coma. And then for the adrenal, we talk about the adrenal crisis. So these are basically the 5 things we're going to talk about, and we'll look at how to manage a patient who has presented in AIE, but this is for exam purpose, for theory exam or clinical, as the case may be. Now, the first one we look at is DKA. Now, for DKA, usually you have a patient who presented or who presents with, let's say, we have a 25-year-old boy, or we can say a man now, at this age, 25-year-old man, and then present with the history of worsening polyuria, polydipsia, dipsia, polyphagia. So, and it has these features, and which is, let's say, weak duration, and the patient has features. Let's say you have features to suggest infection, and you have features in keeping with DKA. But now, how do we manage these patients? Now, in management generally, for medical emergencies or any form of management, we talk about the clinical presentation, we talk about findings. As clinical presentation has 2 parts, which is the symptom and then also the examination findings. And this is what we call signs. Then for the other parts of the management, we involve the investigation. And then this too is more about the diagnosis and then differentials. Then we now talk about the treatment. And for the treatment, we have the medical, we have surgical treatment. For treatment, medical involves both the pharmacological and the non-pharmacological. So it's part of the medical treatment, and we have the surgical treatment, which can be forms of intervention. Then sometimes the medical can have the interventional, can be interventional. So for medical, pharmacological, non-pharmacological intervention, you don't have surgical treatments. So this will be the approach for management. So in exams, usually you introduce, and what should be your introduction? You can talk briefly about the definition of terms, then briefly about also epidemiology if you have, and then also the risk factor if you can, then slash the pathogenesis. So these are what one can summarize briefly in terms of the introduction. But if you have very small amount of course allotted, you don't have to go into all this. So, but the key parts are the clinical presentation, the investigation, and then also the treatment. So I now talking about DKA. So we'll talk about the clinical presentation. Now for DKA, what are the symptoms the patient will likely present with? Now patient can present conscious or patient can present unconscious, either way, depend on the severity. And then usually for patient when they present, the symptoms they can have include, like we said earlier, classical symptoms of hyperglycemia, which is what they can present with, and this is the polyuria, polydipsia, and polyphagia. So that's what they have. So the PPP. So that's what they have. Part of what they present with. Then they can also have visual blurring. Okay, they can have. So they can also have that, and then of course because of the polyuria they lose weight too. So can talk about weight loss that they can have. And then we talk about the precipitants in this case, which can be infection. So they can come out with fever, or can come down with maybe some forms of features to suggest the source of infection, like cough in case of pneumonia. So these are things the patient can present with, and of course, the patient can have altered level of sensorium. So as the case may be, so these are things that patient can have. So, but by and large, when they present, usually they present with classical symptoms, and they can have respiratory symptoms too. And this one, they can have cosmo breath. So these are what they can present with. So then this is a typical clinical sign, that you see in there. So they can have cosmos breath, and the smell will be fruity. That's the smell; it will be fruity. So and that is ketone breath. So that's about the presentation. So usually for the diagnosis now, for the investigation now. So it's bound to do two things at bedside: urinalysis. Then you check for glucose too, using a glucometer. So we talk about the glucose check. So for the glucose check, what you have, we said that for those who have DKA, they have hyperglycemia, so meaning that if you are using millimole per liter, so it's around 14.5 millimole per liter to 3.3 millimole per liter. So, and that's the range of a patient with DKA. And so usually for HHS, they have higher values. Then urinalysis, you have glucose 3 pluses or greater. Though we don't use the urinalysis for glucose check, we use the glucometer for glucose check. But for analysis, you can have ketones in the urine, so that can also be for that to be tested diagnosis. But the things you are looking out for, like the name implies, DKA. The first part we said diabetic, then we said keto, then we said acidosis. So those are the three things you look out for. Number one, hyperglycemia, and we say we prefer the use of glucometer to do that. So, and the values you are looking out for goes for 14.5 to 3.3, and this is in millimole per liter. Then you are looking for ketones, and then you can check for serum ketone, and you are looking out for values of 5 millimole per liter or greater. So, and for urinalysis, have the process of ketones in the urine, but this you should understand that can be affected by hydration, and so it will not be that reliable, and so if you have fewer ketone in the urine, fewer process of ketone in the urine, might be because the patient has not been properly hydrated. So the best way is to use the serum ketone. And then for the acidosis, usually we can talk about the metabolic. That's what they have, metabolic acidosis. So in metabolic acidosis, that's what they have. And what are the features of metabolic acidosis? That's what you're looking out for. One, you have increase in pH. Sorry, that's a mistake. It should be decrease. Increase acidity, but that's going to be decrease in pH. But the hydrogen ion concentration will be high, but pH will be low. So decrease pH, that's acidosis. And then 2 is going to be the low bicarbonate, which is very important. And then values, some like in our hospital here, to use 20 to 30 millimole per liter. So we're talking about values less than that now. So these two tells us that we are dealing with metabolic acidosis, but often there's a characteristic that is also seen with acidosis, diabetic ketoacidosis, which is the increased anion gap, so which is going to be part of what you are looking out for. So you also look out for the anion gap too, and so when you do that, so you have the value of what you are looking out for. So that's the key thing there. So, and the values vary. Well, for some, we talk about 6 to 12 millimole per liter, and then that's for the normal anion gap. So, but in a patient with diabetic ketoacidosis, they have high anion gap. And you can also know the cause of high anion gap, cause of normal anion gap, and acidosis, and then cause of high anion gap acidosis. So these are what you look out for to actually make a diagnosis of diabetic ketoacidosis. But other investigations include usually we investigate for 4 reasons. 1, diagnosis, to establish a diagnosis. Then to rule out differentials, which is very important. Then 3, to prognosticate a patient. Then 4, to follow up on the patient. So these are reasons why we do investigations. So then after the investigations, the next thing you want to do is you want to treat. So the goal, what is the principal treatment in patient with DKA? Now the principle includes 1, you want to hydrate the patient, which is very important. That's where it begins from. You have to hydrate the patient. Number 2 is that you want to correct electrolyte imbalance. And this is very important. So fluid and electrolyte is the first part of the management, and 3 is now to control hyperglycemia. So the first is fluid, you want to hydrate. Second, you want to correct electrolyte imbalance. Third is you want to now control hyperglycemia. So the fourth is to treat the underlying precipitant. Then 5, you want to prevent complication, which is very important. Prevent complication and address any complication. Or you prevent complication, then identify and address any complication if there is. So the sixth one now includes supportive care in this patient, and 7, you want to rehabilitate the patient, and follow up to prevent reoccurrence. It's very important. So this is just a summary of what we do. Now the first part is to hydrate. So we look at this to take care of our patient. In DKA, usually it is said that patients fluid loss is around 6 to 9 liters, and this is as against EHS, which is around 9 to 12 liters too. But not like you are giving the whole 6 to 9 liters at once. So usually we give the first liter fast, so second liter some to about 30 minutes, then third liter over 1 hour, then fourth liter over another 1 hour. So but we must note that this may not apply to every patient. So the most important thing is to individualize your patient, which is very key, because we have a patient who has other comorbidities that may not tolerate aggressive fluid resuscitation, and then apart from that, you look out for the hydration status of the patient. So it's not like this fluid regimen approach is typical to all patients, so you have to individualize the patients. So then you can continue the fluid as the case may be, like 1 liter 6 hourly. So the next thing I want to check out for, we talk about the second part, is electrolytes. And so in this case, potassium, sodium is of utmost important. Though it's assumed that before you even start the fluid, you have checked for that, because if a patient has hypernatremia, your fluid resuscitation would be with 0.45% normal saline. Sorry, 0.45% saline on normal saline. Normal saline is 0.9%. So this will be 0.45% saline if patient has hypernatremia. So, but now I have I don't want to check up. What you want to look out for is potassium. So usually the values that is normal in our hospital here, we use 3.5 to 5.5 millimole per liter. So milli equivalent per liter. So this is the normal value. So for a patient who has presented with a normal value, you want to maintain, because when you give insulin, it drives in potassium. So you want to maintain at this value, you want to maintain. But if a patient presents with higher value, you want to hold potassium, potassium fluid and so on while you watch the patient. And of course, it's expected that you repeat the electrolyte tests every 4 hours. It's very important. So, and you adjust your fluid accordingly. Now, if you have hypo, you have to first correct. So you first correct for deficit. Now that's what you do. How do we correct for deficit? To correct for deficit, we talk about the value of what you want to correct in millimole. So that'll be in millimole. It's going to be equal to the value of potassium you get, which is going to be the difference in the value of potassium you've gotten, and then the normal value. So the normal value, which usually we take to be 4, minus the observed value. So the difference in this is very important. So plus 0.4. This value here must be multiplied by patient's weight. So whatever you get, multiplied by the patient's weight, which is very important. And also multiply by 0.4, not plus. Multiply by 0.4. So in other words, so you have the value to now be 4 minus observed potassium times weight times 0.4. So, and usually you divide the values over the fluid you want to give to the patient. You cannot give more than 40 millimole in 1 liter. You cannot give more than 40 millimole in 1 liter. So if your deficit, let's say for instance, now patient has potassium of 2, we use 4 as the average normal. So 4 minus 2 will now be 2 times, let's say the patient is having a weight of 60 kg, times 60 times 0.4. So this will be 4 times 6 times 2, and that will be 48. Sorry, am I making a mistake? So 4 times 6 is 24. Yeah, I'm correct. So this will be 48 millimole. So 48 millimole. So you can divide it and give 20 millimole in successive fluid, and that can be given. So, and you can continue, usually continue by adding 20 millimole in each liter of fluid. So, and that will correct it. And then also you can maintain. How do you maintain? You talk about the value in millimole per kg. So if a patient is 60, so that's 60 millimole per day. We use for maintenance, we said it costs to millimole per kg. So for 60 kg, that will be 60 millimole in a day. So 60 millimole per day is the maintenance, and we have a deficit of also 48. So plus the 48. So this is about 108. So that's what it needs for that day. So if he needs 100 per day, so it means that you have to find a way of dividing this 108 into the fluid you're going to give to the patient in emergency, in which you won't have more than 40 millimole in 1 liter. And that's very important. So I would just say you still need to check up 4 hourly for electrolytes. So, and that's for a patient who has had values that is less than 3.5. But if it's between 3.5 to 5.5, you maintain. And what do you maintain with? In a patient with 60 kilogram weight, so you have 60 millimole. So in this case, you can give 20 millimole in alternating the liters of fluid, so that you maintain with that, and then you watch, still measuring the electrolyte values every 4 hours. Sorry, just like that. So you have to every 4 hours you measure it. Then that's that for the electrolytes. So you control hyperglycemia. So you use glucose. Usually we talk about 0.1 international unit per kg. So for a 60 kilogram man now, we talk about, you can do 6, that's per hour. So it will be 6 international units per hour. But you can adjust it as the case may be if you are not achieving a good control. But there's a target anyway. So, and the target is usually to bring down the blood glucose at a rate. So the rate is 50 to 75 milligram per day. So if it's less than 50 milligram per day, you are underdoing it. If it's greater than 75, you are overdoing it. And so usually you can have the dose if you are overdoing it. For instance, as if you are using 6 international units and you realize that after an hour you check the blood glucose and it's having, you have a drop of more than 100 milligram, then you can reduce the dose of insulin by 2 international units, or you can have the dose. And if you are getting value that is less than 50, you can double the dose. So usually patients will have high level of glucose, and the goal is not to crash the blood glucose to normal, but you want to bring it down. And then when you now get to 180 milligram per dl, you want to maintain for a period of 24 hours, and until patient can tolerate orally. It's very important. So, and usually when it gets to 180, you want to change your fluid from the 0.9% saline to a glucose containing fluid. It is very important. So, and you maintain in that. So when you maintain that after 24 hours, then you can, then if patient can tolerate orally, you can then find a way to convert to the we can change to the usually we use the soluble insulin for resuscitation, which is very important. Then you can change, you can still continue with soluble insulin, but you can give it with meals now, because patient can tolerate orally. You can give it with meals rather than the infusion that you are given before. So, and then again, you have to also treat the precipitant. So, but this one is not like it has to come after the control of hyperglycemia. You can do the same. You can do them concurrently, because antibiotic, if it's infection, has to be given, and that's very important. Then you prevent complication. This might involve use of anticoagulants. This is important. You want to anticoagulate the patient, so you want to prevent complication. And then supportive care. This has to do with diet, social. If a patient has then fever, you want to tap a sponge, and so on and so forth. So family support. Then the support could be disease related. Patient has fever, you want to tap a sponge. Then it could be diet, could be social. These are different forms of support the patient can benefit from. And the social will involve family. You understand? So these are then for rehabilitation. It is important to follow up of the patient. So after you must of course educate your patient on the disease process, then how he can take care of himself at home, and then how he can get back to the society and be productive. Then you have to counsel him on diet, the diabetic care generally. You have to counsel your patients, and then you follow up. You book a clinic appointment and ensure you follow up on your patients, and you investigate for other things too, which are comorbidities in the patient. You want to establish the type of diabetes the patient has. If the patient is just presenting for the first time, you are dealing with a type 1 DM or you are dealing with a type 2 DM, and then you want to know why the hyperglycemic complication has occurred, and you want to prevent reoccurrence. All these are achieved through proper follow-up in clinic. So, and this is just the summary of that, but I try to touch the salient parts, so you can also read up on it. So we'll stop for now. Thank you. So we continue in other recordings on the other forms of emergencies.